You're listening to the Patient Advocacy Now podcast, presented by Greater National Advocates.
It's just gut-wrenching sometimes. Like, if it's sad and they're crying, I might cry.
Amazing how many doctors do not even want to treat somebody who has Medicaid.
Medical system is about making money.
And I said, so are you hiring more nurses, or you're just telling each nurse to work harder?
Nan Wetherhorn, thank you so much for being on the Patient Advocacy Now podcast. I'm really excited to talk to you. I love your background. You've been a nurse forever. You have different, every nurse has their own story of what they specialized in, what they bring to the table, what units they were in. So before we even get into advocacy, let's kind of let the people learn a little bit about what I've learned about you, before the mic was on and in your bio and whatnot.
Okay. I've been a nurse since 1976 in neonatal, pediatric, and adult ICUs, mostly teaching hospitals. And I've actually worked all over the world.
What do you mean all over the world? In Europe, in Asia? Where do you mean?
In Europe. I've worked in Europe and in North Africa. Yeah. So I did it before there was really traveling nursing started. So it was very interesting. I just had to learn to speak French.
What took you to France or whatever French
speaking?
Took me to
Switzerland.
Switzerland. Okay.
Took me to Switzerland. Well, I graduated from Vanderbilt University and I worked as an aide in the neonatal intensive care unit. And the doctor at the time had fellows from all over the world. So she said, well, I've got one in France and several in Sweden. So I wrote to them and said that, I'm looking for a job as a nurse in the neonatal ICU. She recommended me. So
how long were you there for? 2
years. And I was in Lausanne.
Lausanne?
Outside Lausanne, Lausanne. It's outside of Geneva, about 45 minutes outside of Geneva.
I actually think I have a friend out there. I might have visited there.
It's a teaching hospital that's there.
Wow. Did you, I know it was a little while ago, but did you find a huge difference in the way Europeans practice medicine than Americans?
Well, actually, it's not the medicine. They use the textbooks that we had in the United States on neonatology. But it was really funny. They were all in English, and most of the people they were not allowed to speak to me in English. So some of them didn't really, the English, they couldn't read it so well because some of the machines were our machines. And I would say, no, you're not using that correctly. And they go, yes, we are. No, see right here. It says right here in English. This is what it says. So it was very challenging in the beginning because I did not speak French. I went to school in the afternoon and I worked in the morning. And it took me a good 6 months, 3 to 6 months before I felt very comfortable.
With the language?
Mm-hmm, with the language. No, the work was fine. The work I knew backwards and forwards. It was saying it in another language. And I figured babies, they don't speak. Unfortunately, their parents do.
Yeah, that's true. Did you become fluent in French?
Yes, and I'm still fluent in French.
How did you hold on to it?
Okay. I also worked, after 2 years, I came home and worked in the United States for 2 years. And then a friend sent in, as a joke, they sent into Club Med. They were looking for nurses. And I went for an interview. When they called me, I don't know what this is. And my friend told me, I said, great, I'll go for an interview. So you change countries every 6 months with them. So I worked for Club Med as a nurse for 2 years.
Oh, wow.
And I was in Cancun, the Bahamas, Cabo Negro, which is on the Mediterranean coast of North Africa, and Copper Mountain, Colorado, and the Dominican Republic.
Do you still enjoy traveling, or did you kind of get it all out of your system?
Well, I still traveled after that, but most of it, I didn't do it like that because every 6 months is a lot, and you work with different medical systems. And Morocco medical system in the 80s wasn't great.
Yeah.
Yeah. The little one, the hospital near us, not so good. I had to take people into usually Tangiers or Casablanca.
Was there
Usually 10
anything
years.
from you not studying, but working abroad where you thought we should bring this to the States?
Yes. As a nurse, well, no medical person was allowed to wear their clothing that they wore in the hospital outside of the hospital. So you came in, you changed into a uniform and shoes that you could only wear in the hospital. Then for the neonatal ICU, we walked there, and then there was a changing room there. We had to change again. And the scrubbing was a 5-minute scrub for your hands.
Wow.
And then they did swabs of your nose, your shoes, and your fingernails once a month.
Wow. So there was a lot more kind of germ-centric kind of awareness.
It was Switzerland, okay? Yeah. Very, very strict on being clean.
Wow.
So yes, I was like, this is amazing. We should do this. So and when I came back to the United States and worked as a nurse, I didn't wear my scrubs to work. I would wear other clothes, put my scrubs on at work, and then go into the unit.
Yeah.
Same with the shoes.
Huh. So getting back to, other than being in all over the world, you specialized in babies and adults in the ICU?
I just did ICU. I worked with babies. When I was in New York, I went from babies to adults, which was too big a change. It was really scary because all the adults in the ICU were like 250 pounds. So I went from 3 pounds, maybe 6 pounds, to 250 pounds. And I was always triple checking the medications, thinking, you are going to kill these people with this medicine, giving so much. And then because you do it by weight. And I was like, oh my God. So that was a challenge. I also did pediatrics when I was I went to California to do pediatrics as a traveling nurse. Mm-hmm. So I did pediatrics and adults and neonatal. But yeah, I think children are so much more honest than adults when they're sick, especially. You ask them if they hurt, they say yes. They tell you where. You ask an adult, oh, no, I don't know. It's not pain. Well, your heart rate's going up really high and your blood pressure's going high too. So I know you're in pain, and it's probably more on a scale of 1 to 10. It's probably close to a 7 or an 8. And they look at you and go, you're good.
Why do you think people hide their pain from nurses and doctors?
I don't know. I think men do it because they're real macho and, oh no, we don't feel pain. And because they're the ones that have had the hardest time with really admitting to the pain. Women are pretty good. Women are pretty good about, except for when they're having babies, they just expect the pain to be really bad. But no, I had mostly men that would tell me, no, I'm not in pain. And I'm like, oh, yeah, you are. And why? I think people think that they don't want to feel weak, seem weak, I guess.
Right.
But I would always be like, tell me you're in pain. You don't want to be,
you're at the ICU. You're in the hospital. Like this is.
Don't worry, we'll take care of it.
Yeah, that's so funny. That's so interesting. So what was the journey from being a very seasoned nurse, and what caused the switch over to wanting to get into advocacy?
Well, starting with babies and children, you are their advocate because they don't talk. So you learn, the longer you're in neonatal, you learn that their facial expressions, the way they hold their hands, you learn to watch them and to watch them monitor and go, yeah, we have to stop people from touching them because that's starting to make them go a little bit freaking out. Just let them be calm, let them calm down. So you learn that there. But the reason I went into advocacy full force, my mother was diagnosed with cancer, and it was in 2000. And my mother was very smart. She really was. She was a pharmacist. She went to pharmacy school at Columbia during World War II, when women didn't do pharmacy.
Yeah.
So she knew what was happening. But when the doctor said to her, you have cancer, we think you have ovarian cancer, my mother looked at him and said, stop. talk to my daughters. My sister we went to Atlanta for that, to Emory. So she said, Nan is a nurse. Jan lives here. Talk to them. They'll tell me everything because you just told me I'm going to die. That's what cancer means to me. And so I thought then, oh, what happens if you're by yourself? You probably think the same thing, but then you just stop listening to what the doctor says. And most of the time they don't tell you you're going to die tomorrow.
Right.
They tell you a plan of care and you can't concentrate on it. So that's when I decided to do it.
Is that the population that you specialize in, kind of chronic or kind of, severe
I deal
illness?
with anybody because I like all the different things. I went from neonatal to pediatric, neonatal to adult to pediatric and back to adults because I like the difference. And I've done medical, surgical, ICUs. So I like all the different things that you can learn. No, I don't have one particular population. I do have children that I've been an advocate for. I'm in South Florida, so basically I have a lot of older people that the families call me, and they're like, they're killing my mother in the hospital. You've got to go get her now. And I'll give them, I'll say, could we start with your name? Because that is exactly how the call starts. And I'm like,
wow. Wow.
So let's go back and start with your name. And now what's your mother's name? Now, where is she in Florida? What city is she in? And it's like pulling teeth. But
That's so interesting. When you, because of your nursing background, I assume there's a lot of clinical kind of guidance, other than kind of helping people in dire straits when they can't take care of their parents because they're just too far away. Where do you see your role start and stop as an advocate in terms of the guidance you give and the information? Kind of where do you say, you know what, I'm not going to do this, or that's inappropriate, and this is where I'm, used. This is where my value is at its highest point.
Right. As an advocate, I deal mostly with the clinical and the medical side. And I will say, they'll say to me, my father's not paying his bills. Can you do that? No, I really can't.
Right.
That is not my area of expertise. I have a hard enough time for my own, so please, I'm not going to do yours. And I try to make light, I just don't do that for anybody. It's not just you. But I can recommend someone.
Sure.
So I've tried to have resources so that if I don't do this, I'll recommend someone. Like fighting health insurance companies, I don't do that, but I'll find someone who does. Mm-hmm. So that's what I do for my clients. I try to get them all the resources they can that they could ever ask me about. Sometimes they come up with different things. I'm like, ooh, didn't hear that. Let me see what I can do for that. But yeah, I try to find the resources they need if I can't deal with it. And yeah, there are times I'm going to say, yeah, you need to call the doctor. Mm-hmm. This is something you really need to talk to a doctor about, not me.
And when to put it a little bit more detailed, the clinical kind of guidance you give, is it coordinating between specialists and primary care? Is, how much of it has to do with medications? How much of it has to do with...
I do all of that part. That part is, for me, that's the most fun. And the medications, I'll always confirm with the doctor. I'll go through the medications. I'll go, 2 blood pressure medications. There are people that need 2. I wonder if this is that type of person. So let me send the medication list to the doctor, fax it to the doctor's office. It's their nurse practitioner that'll look at it usually. And just highlight or put a star by all the ones or a question mark with all of them. And I usually get a call back that says, why are they on both of these? Interesting, you should ask. I asked the same question. You're the primary doctor, so I start with you. Well, who wrote that prescription? I said, the doctor's name is right next to it. If you'll look, I put it on there for you. Mm-hmm. Okay, cardiologist. I'm like, because doctors don't talk to each other. Sadly, they don't.
And so how do you, as an advocate, get them to talk to each other? Do you just call them individually?
I talk to the primary, and I always say, do you want to talk to the cardiologist? And if they say no, I said, then who's going to? Do I need to do that? If they say yes, I do try to push back because that's really not the role of an advocate. That's the role of the doctor to deal with the medications. Now, I will call them and I will say, you both had this medication. Dr. Smith stopped it. He's the primary. I wanted to be sure you knew about that. Have you talked to him? No, I haven't, but I'm going to call him. Okay, Mr. Cardiologist, you do that. But I also keep a chronologically ordered medical timeline for each of my clients. So every time I go to the doctor, it's just a few sentences about it. And if they made any changes, what the change was. And I keep a 3-ring binder for each of my clients in their home. It's the hard copy because a lot of my clients are elderly. They don't do the computer thing.
Right.
So they'll go through and look at it and they can read what happened at the doctor's meeting. Oh, he didn't say I had to take that pill 4 times a day. Nope. That's not what it says on the prescription bottle. That's not what it says on your medication sheet. And that's not what the doctor said.
Right. So just keeping track of things is a big deal, especially as you have kind of multiple diagnoses or you start getting up in age.
Well, when you have 9 doctors and they don't talk to each other, I always ask the primary to manage things, but I always check to be sure that it's being managed appropriately.
What's the hardest part for your clients that, you feel like you take a big weight off of their shoulders?
Making sure that they understand what the doctor said and that they follow through with it.
And how do you do that? Are you in the room with them? Are you reviewing notes?
Okay, because my fee is not cheap, I tell my clients, if you don't want me to sit and wait with you to see the doctor, totally understand that. Call me when you're in front of the doctor, and then I will ask questions, and I'm listening and I'm writing everything the doctor's saying. And I tell them before I start, I'm going to be taking notes and writing everything down. I can send it to you so you can review it, see if I've missed anything. Usually I don't, and the doctors are like, oh, I forgot that I said that. That's good, thanks. And it becomes part of the medical record. So the doctors love me too.
Yeah.
Because it's just taking notes and making sure
it's organized, it's clear,
information. Yes.
Everybody's on the same page. Sure.
Exactly. And that the client can go back and read it afterwards and go, I thought it was worse. It's really not so bad. And I have gone to the portals. They give me access to the patient portal. And I have found once or twice that the doctor's note didn't match what the doctor said to us in the appointment. And I let the doctor know that. And I got a call from the doctor that said, I am so sorry. I used a template and I didn't watch it. I didn't watch things. I'm going to go back and correct it right now. Thank you for catching that.
Yeah. A lot of people just get too busy. I mean, doctors are human and they make those mistakes.
That's the thing. And I tell people, you don't expect your doctor to be like Marcus Welby, like the old-fashioned doctors on TV, because they don't do that anymore. If you go to a teaching institution, most of the doctors there, in order to maintain their position, have to teach, see patients, and do research.
It's a big load.
And seeing a lot of patients. I mean, I'm very lucky that the doctors I choose for my clients, because I find second opinions for them, and they have spent an hour with my clients.
Wow.
An hour, even on Zoom. Yeah. They turn the screen around so you can see the x-ray, you can see the CAT scan, go through everything. Really, really incredible. So I'm very fortunate that I have doctors that I can go to and say, who would you recommend? And I know that they're going to be just like them.
That's wonderful. That alone is worth the price of admission, getting the right connections, the right doctors.
Yes.
Yeah.
I have people who've hired me just to get them a second opinion.
Amazing. So what's some good advice you would give? Let's say you get a new client. The first thing we're going to do, is you start the 3-ring binder or you get the history.
The first thing I ask him is, what's the problem? Mm-hmm. What's the main issue? Then what's the second issue? And once I say, what's the problem? That's usually 30 minutes.
Yeah.
And it's every problem.
Yeah.
And so I'm taking notes the whole time. And then I go back and I say, okay, let's organize this. The big problem is you've gone from the hospital to a skilled nursing facility, and now they're telling you you're on Medicare, you only have like 21 days, and the patient's not doing as well as they thought. So what are you going to do? How are you going to take them home like this? Well, take a step back. Let's see, can we get more time in the facility? How do we do that? Well, we talk to the doctors and we talk to the case manager. Talk to physical therapy, the doctors, the case manager. We're going to have a family conference. You can do that? I said, of course you can. You should do that. You should always ask for a family conference. Mm-hmm. The doctors and the staff need to sit down with you and give you the lay of the land there, how they work, and what we're going to be looking for. What are the milestones that we need to see in order to say he's doing better? What happens when they don't happen on their timeline? So when you put it like that, it's a much calmer, more structured way of doing things. And the same in the hospital. I get so tired of people saying, they're going to kick me out. They're going to put me on the street. And I say, who told you that? They would never do that. Oh, Nan, they said they would. Mm-hmm. And I'll say to them, if they ever really do something like that, I would have every news station in the country here. Hmm. And they would have a field day. Yeah. They will never sit you outside. And I've heard them tell people that. I've heard my clients say that. Nobody would really do that. So I don't know where they get that from. But yeah. So that's my biggest, that really annoys me. It really does. Don't scare people.
Yeah.
They're frightened enough in this situation.
Yeah. No, I remember even with my own grandparents and relatives in hospitals, there was this fear that they're going to be on the street or kicked out prior to getting care. And it is a pervasive fear that you hear from a lot of patients.
Yeah, the elderly usually are afraid, especially if they've got nobody there. And I love it. You asked what makes me feel good? When the client calls me and says, Nan, they said I'm going to be discharged today, but they told me, don't worry, you're taking care of everything. Because I've already given them the day of admission. I've given the case manager my top two choices of if they're on Medicare nursing company. I've given them my top three choices of home care, private home care, if they need that. I've given them my top two choices of rehab facilities if they need that. They have everything they need. And they're not going to leave unless I'm there to take them out, and they know that.
Yeah, that's kind of an end-to-end white glove kind of service.
Yeah.
So one thing I also was really struck by with the way you run your advocacy business is you really push for people to learn how to be their own advocate and to kind of do the digging themselves and kind of get their hands dirty and to do it early. You know, to people in their 20s and 30s can kind of get a head start. You don't have to wait till you're in your 50s, 60s, 70s to take your health seriously. And you've put together a really interesting kind of resource called the Map to Good
Health for Healthy Living.
And you can find, Nan's gonna talk more about this, but you can find it online at livinghealthywithnan.com. That's NAN. So livinghealthywithnan.com. You can read more about it, but tell me in your own words, what was the impetus for this? First of all, what is it?
Okay. It's this 75 plus questionnaire that contains all of your health information, your insurance information, everything you would need to have when you go to see a doctor, if you go to an emergency room, if you go to an urgent care center, everything is there. So you don't have to remember it. You've already done it. Now, it's like 6 or 7 pages. It includes your medications, everything. But it's what you need to be able to give a doctor. And it includes your health history and your family health history, which is so important nowadays. We know all about that, how that can help doctors take better care of you. So that's what this particular thing is. And I think everybody should have one because, like I said, no more Marcus Welby. You got to take care of your own health. The doctors can only work with what you give them. And half the time, I think anybody out there will tell you, oh, I went to the doctor and I forgot to ask him about this, or oh, I forgot to mention this. It's kind of important. I wonder, should I call him back? You won't have to do that. This will have everything you need right there.
Yeah. I love that idea. I love I'm a big person who believes in preparing. The better prepared you are, especially when you consider the doctors often only give you 10 minutes. And so if you're not prepared when you go in for those 10 minutes, you can blow them pretty quickly just saying, oh yeah, I'm fine, I'm okay. Or if you're a guy and you don't want to kind of, really be super honest about the pain you have, then it's not going to go so well for you.
Well, and I add at the end of this, I add questions you need to ask your doctor, and I break it up into men, women, and children. And basically, men, they hate talking about the prostate cancer, but ask about your PSA. When do you need to start with that? Women, when do you need to start with a mammogram? When do you need a BRCA test? What's it for? Is this important in your family history? So that's why, and I really think people need to know, particularly breast cancer and female cancers are more prevalent in Ashkenazi Jews. So is that your background? Is that your culture? Your doctor needs to know that. So those are some of the things that I put in there. But yeah, and it comes with little bonuses to help you with prepare for an emergency room visit, how to be your own patient advocate, the questions to ask, what you need to think of, a little brief PDF that's about how to navigate the health insurance piece. And then I also put in there what a functional medicine doctor is and what's different from. So yeah, functional medicine versus conventional medicine for the elderly, the benefits of using a senior placement specialist, how to find your perfect doctor, and how to leave your current doctor if you don't like them in a nice way. So those are some things, and it all comes from questions people have asked me. And because I've said to people, you need to leave your doctor. Oh, honey, I've had him for 25 years. So, well, it's time to find a new one because he's probably going to retire soon.
Yeah.
Oh. So, and some of the times we have to change doctors because of their insurance. They go to an Advantage plan or a plan that they're no longer in the network for. And that's very disconcerting for a lot of elderly people. So I try to help them with that. And so this has things that you can do it yourself. It's
or
just
for your loved
time-consuming.
one if you're helping out your mom or your dad. Sure.
Exactly. For your husband, look, we know the wives are the ones that usually take care of everybody's health care. They call and make the appointments. They talk to the doctor. They call the pharmacy. So this is a way to help them manage all of this different health care.
Yeah, totally. Well, I think it's an amazing resource. I can only imagine how happy a doctor would be to have this handed to them.
I have actually used it I've walked in and handed it to a doctor, and it was at a teaching hospital. And he actually looked at it and he turned to his fellows and residents. He goes, "This is why you need a patient advocate. Look at this. Look at this. This says everything that we need to know." He said, "She could be unconscious. It would still be fine. We have all of the information right here." And I said, "Thanks a lot." But it is true, because for my clients that have gone into emergency rooms, I fax. If I can't go with them during COVID, I could fax it in. And I would call to be sure they got the fax. Mm-hmm. And the reception person would say, "Just a minute, the doctor needs to talk to you." And the first question is, "Did you do this?" I think, "Yes, I did. Who else would?" And they go, "This is fantastic, because the patient's having a hard time talking." I said, "I know, he's on oxygen. It's hard. So this should answer all of your questions. And if it doesn't, please call me, because I do have the answers for you." So that's something I take off of the patient's shoulders and the family's shoulders. So, yeah.
Nan, it was amazing learning about your kind of amazing travel journey as a nurse. And I know that I'm probably going to be picking up the Map to Good Health for Healthy Living. For my family, I'll probably leave it on my wife's desk for her to fill out, like you said. And again, the URL for anyone listening is livinghealthywithnan.com. Thank you so much for being on the podcast.
Thank you so much, John. I appreciate it.